Hello, this is Josie Conte, and I am here representing Central Maine Medical Center Family Medicine Residency in Lewiston, Maine. And we want to thank you so much for inviting us to Family Medicine Education Consortium, October 2020. I'm here with my colleagues to present a design for a workshop. It's not all in your head, an integrative approach to headaches. The point of this workshop is to be able to give you small bites of what each of us might offer to our patients in the clinic setting. And this is reflective of a 5-model concept in osteopathic philosophies. For an example, we know that the root cause of headache is multifactorial, but we can look at the different models to help us to see a variety of ways that we can treat our patients. Biomechanical through postural mechanics and looking a little more closely at musculoskeletal system, the neurologic model to look at the balance of the autonomic nervous system, visceral somatic integration, respiratory circulatory model, looking at diaphragms, but in this instance we'll be talking about the circulation of qi or lymph and blood, metabolic energy model to look at endocrine function, immune function, and behavioral model to investigate the way our perception of isolation may affect our perception of pain. I think I thanked FMEC. If I did not, I'm thanking you now. I also thank my colleagues at Central Maine Medical Center for all their hard work and transforming this workshop into a 30-minute presentation. We have nothing to disclose, and our participation does not infringe on any copyright or intellectual property of any third party. We have some favorite teaching points to demonstrate. In an ideal world, we would have 120 minutes. We might do this with a didactic session with our residents and medical students in 5 areas of the room, and have small groups of our residents rotate through the different sections. So I will now head this way and introduce Ian Corbett.
Hello, my name is Ian Corbett. I'm a second-year resident here at the Family Medicine Residency, and we're going to start today by giving a brief overview of headaches. So headaches are classified or are defined by the International Classification of Headache Disorders. And starting with primary headaches, there are migraine headaches, which classically present as unilateral throbbing headaches and can be associated with nausea, vomiting, photophobia, and phonophobia. And they're broken into 2 groups, being migraine without aura and migraine with aura. Next, there are tension type headaches, which are the most common headaches in the general population and classically present as bilateral, non-throbbing headaches without other associated features, and are further broken into infrequent episodic, frequent episodic, and chronic tension type headaches. Next, there are the trigeminal autonomic encephalgias, which are a group of headache disorders with unilateral trigeminal distribution with ipsilateral cranial autonomic features. And lastly, there are other primary headache disorders within the primary headache group, which include those associated with physical exertion, those attributed to physical stimulation, and epicranial headaches. And next, there are the secondary headaches, which are, as listed, headaches attributed to trauma or injury of the head and or neck, headaches attributed to cranial or cervical vascular disorders, such as stroke and subarachnoid hemorrhage, headaches attributed to a non-vascular intracranial disorder caused by both increased and decreased intracranial pressure, headaches attributed to a substance or its withdrawal, headaches attributed to infection, which can be caused by both intracranial and systemic infections, headaches due to a disorder of homeostasis, headaches or facial pain attributed to a disorder of the cranium, neck, eyes, ears, nose, sinuses, teeth, mouth, or other facial or cervical structure. And lastly, headaches attributed to a psychiatric disorder. And next, it is always important to look for danger signs, which can indicate possible underlying pathology. And those danger signs include systemic symptoms, including fever, neoplasm history, neurologic deficit, including decreased consciousness, headache that is sudden in onset or abrupt, headaches with onset after, new headaches with age of onset after 50 years, pattern change or recent onset of a new headache, headaches associated with positional change, those precipitated by sneezing, coughing, or exercise, papilledema, progressive headache or atypical presentations, pregnancy or peripartum, painful eye with autonomic features, post-traumatic onset of headache, pathology of the immune system such as HIV, and those associated with painkiller overuse or starting a new drug at the onset of a headache. And of course, any of these symptoms or any of these findings warrant further investigation, including imaging of the brain with MRI or CT. And as noted above, there are many different types of headache with common familiar treatment modalities, including treatment with beta blockade, calcium channel blockers, NSAIDs, and antiepileptics. And my colleagues who will follow will provide an overview of non-pharmacologic treatments of headache. Thank you.
Hi, I'm Lauren Nadkarni. I'm a faculty member here at the CMMC Family Medicine Residency, and I'm going to talk a little bit about the anatomy and some referred pain patterns that you might see in the head and neck. So as we were discussing, the head and neck is a very complex region, and there's often a multifactorial cause of headaches. So you'll see a multifactorial approach to treating headaches through this presentation. As you can see on the slide in front of you, there are multiple layers of structures in the head and neck. I'd like you to pay particular attention to some of the more common bad actors in this group. For example, the trapezius muscle, which you can see is the large, most superficial muscle here in the group. The splenius capitis, which is a layer beneath that. The sternocleidomastoid, which you can see all the way to the left of your screen. As well as the scalenes can also be really important here. And you'll see some techniques that are directed towards the suboccipital muscles in just a few minutes as well. All of these structures, all of the muscles and the tendons also connect to the bony structures as well. And so it's important as you're using your palpatory skills to elucidate whether pain is coming from the muscles, the tendons, or other soft tissue, or even the bones themselves. So there are three types of pain patterns that you might see from the head and neck. The first is referred pain. So that would be pain generated from the bony structures in the neck. As you can see on this image here, the green most superior area is a common referral pattern for the C2-3 area, whereas the yellow area on your screen is more related to the inferior part of the cervical spine, the C6-7 region. So if you saw pain that radiated throughout those regions, you might consider the etiology to be related to different levels of the cervical spine, and this is referred pain. This referred pain is different from radicular pain, which is pain that comes from irritation or injury to the nerves as they're exiting the spinal canal. And there's two common ways that we look at this. One is the sensory fibers of the nerves, which you can see on top. Those would be the dermatomes. So you can see each color represents a different dermatome based on the spinal level that that nerve exits the spinal canal. On the bottom part of your screen, you can also see there's functional aspects to this as well, which would be the myotomes, and the pain pattern or weakness may indicate that you have an injury to the nerves at certain levels, so you can direct your treatment based on that. So again, nerve-related pain that comes from the cervical spine or even the head can actually be radicular pain, which is different from referred pain. And then the third pain pattern that we might look at here, which is particularly relevant to our discussion about headaches, is the common referral patterns for the Travell's trigger points. So each of the muscles that we talked about previously has a particular pattern that might vary a little bit person to person, but if you see someone who has headaches in a particular distribution, you may target different areas in their head or neck for areas of treatment. So whenever I'm evaluating patients in the office, I ask, in addition to the character of the pain and how long it's been there and what triggers they've identified, I also ask about what does the pain feel like? How does it travel? Does it start in one place and move to another? Do you notice that if you touch a certain area in the head or neck that you have pain in a different area in your head or neck? Because that can also sort of point us down a different pathway for our different treatment modalities that you're going to hear about later today. So in summary, the head and neck is a very complex area which lends itself to the complex nature of headaches, which can be quite frustrating. But as a primary care provider, we see these concerns quite frequently and try to employ a multifactorial approach and minimizing pharmacologic intervention as possible to try to provide better outcomes for patients. So with that, I'm going to turn this over to my colleague, Dr. Lucas.
Hello, my name is Jessica Lucas. I'm a third-year resident at Central Maine Medical Center. I'm going to discuss osteopathic manipulative medicine, which uses palpatory techniques to diagnose and treat headaches. So these are the 4 osteopathic tenets. These are the foundation of osteopathy. The person is dynamic, interaction of body, mind, and spirit. The body is able to heal itself. Structure and function are interrelated, and treatment is based on these above 3 tenets. As you can see here, there are several osteopathic techniques, but we're just going to focus on one today, conterstrain. This is a system that uses tender points to diagnose and treat. The tender points are considered to be produced by inaccurate neuromuscular reflexes. And the technique puts the tissue in a position of ease, which opposes these reflexes. These are some contraindications to OMM. Any structurally or medically unstable condition would be a contraindication. So if you hear are stroke, subarachnoid hemorrhage, an acute fracture, or increased intracranial pressure. This slide is just to demonstrate the complex anatomy in the suboccipital region, which is the focus of the OMT technique today. As you can see, there are several paraspinal muscles with a complex innervation and circulation, and dysregulation and imbalances in this area can contribute to headaches. And this slide also demonstrates the intracranial anatomy, including the tentorium, which also may be affected by treatments today. So this is the technique we're going to focus on. So I'm going to first assess the tissue. It's called suboccipital conterstrain. So I'm going to palpate, really focusing on the suboccipital triangle, the tissue. I'm going to look for areas of dysfunction, which would include ropey tissue texture, firm tissue, asymmetry in the tissue between the right and left paraspinal muscles, or decreased range of motion, such as with flexion, side bending, or rotation. Once I find an area of somatic dysfunction, conterstrain is performed by placing the tissue in an area of ease. So for the suboccipital triangle, that would be slight extension and side bending, rotation away while you're palpating the tissue. You're monitoring with your hand and holding for 90 seconds. The treatment is complete when you feel the tissue texture changes, such as softening of the tissue. This has the ability to decrease headache frequency, intensity, or in some cases, resolve headaches altogether. By addressing the 5-model complex, this technique has the ability to diminish pain, increase lymphatic flow, and increase circulation. Okay, and that is it for this technique. Now is Dr. Conte.
Okay. Okay, let's see. So I wanted to offer a little information about using acupuncture for headaches. And acupuncture was introduced to the United States in the 1970s, but it's been practiced for over 5,000 years. And when we think about acupuncture or traditional Chinese medicine, we think only of needles, but we can also use heat. We focus on specific points along long lines of energy flow. We might call meridians, and they often will reflect fascial lines. The principle of what we're moving, as opposed to in osteopathic medicine, moving lymph and venous blood and arterial blood, is to move qi, is to move energy. And it is the insertion of a needle or the use of heat, or sometimes just finger pressure along these meridians that can allow for a release of a blockage and allow for qi to travel, to move, and to bring relief. I had listed a study, and this was just among many studies, but there have been studies showing that acupuncture can be equal to or greater relief than pharmacologic applications with less side effects. And the Yang study, a randomized clinical trial, is just one of those studies. So the head is one area that's the meeting point for all the Yang meridians. And that point right in the middle, it says do 20. That is the focus of all of these channels. So that might be an area that possibly would receive a needle, but it really depends on the person's presentation. And in a Japanese style, acupuncture is extremely palpatory based practice. And we start by reading the hara. And the picture to the left, is a diagram that is showing different areas. Those colored areas of the body is reflecting internal organs, or the zangfu. So I would gently palpate each of these areas to see if there was discomfort. And this would give me some information of how I would direct my treatment. What I do in the office often is to use a microsystem. And so the ear is one such system. It's kind of like the homunculus, but it's placed in a smaller region. So you see this image on the slide of the hand, and those are little pieces of ginger with moxa, which get heated, and it's bringing heat and energy to the central portion or the meridian traveling along that hand line. And there you can go and take another peek of that map when you have a chance to look at the PowerPoint again. But the ear is a terrific place to treat. It's simple. It's not very invasive, and the ear is like a reflection of the embryo. So I think that my photo here is blocking the ear map, but you can see an embryo with the head down by the lobe, and the spine curls up the posterior portion of the ear. And I may place small gold needles in the apex of the ear, in shenmen, which is like a heart center area of the ear, and then 0.0 or omega point. And these needles can stay in for up to 4 days if They're very small. The patient can take them out themselves, or they might fall out on their own. I'm going to end my discussion here and hand it over to Annie Derthick.
Hello, my name is Annie Derthick. I am a clinical psychologist and the behavioral scientist here at the residency. I have referrals for chronic pain quite often, and headaches are some of the more common presenting concerns. So I want to talk a little bit about the behavioral health approaches that I might use with patients for chronic headaches. Stress is the most common trigger for headaches. When someone experiences chronic stress, biochemical changes such as increased cortisol can make patients more vulnerable to headaches, and tension from stress can make headaches last longer and feel more painful. So there's actually quite a lot we can do in behavioral health to address some of these contributing factors. If you refer your patient to me, I typically use a cognitive behavioral therapy approach, which first and foremost teaches stress management strategies. We spend quite a bit of time linking cognition and behavior with symptoms and outcomes. So how a patient is thinking about their pain and then responding behaviorally can impact their perception and experience of that pain. We challenge and modify cognitions that can be problematic in that process that tend to precipitate or exacerbate headaches. So for example, pain catastrophizing thoughts such as there is nothing I can do to help my headaches will last forever. Those are pain catastrophizing thoughts, and they are the #1 predictor of chronic pain treatment response. So in cognitive behavioral therapy, we spend quite a bit of time identifying those kinds of thoughts that can undermine treatment receptivity and practice replacing them with others that increase psychological flexibility. CBT also focuses on general wellness. We talk quite a bit about sleep, activity pacing, diet. We provide psychoeducation around the gate control theory of pain, as well as centralized sensitization. We practice relaxation strategies such as progressive muscle relaxation, which is particularly effective with headaches. We spend quite a bit of time on mindfulness, such as guided imagery. Biofeedback is another technique that's folded into CBT. It involves using equipment to provide synchronous feedback of physiological function to the patient while they practice the strategies that we've learned in CBT. So for example, muscle tension and temperature are the most common stress reactions, and they are very easy to measure objectively. We might use an EMG machine, which measures muscle tension while the patient is practicing progressive muscle relaxation or cognitive reframing, and the patient gets real-time feedback of how those interventions are actually changing their physiology. Biofeedback is 40 to 60% effective in reducing headache pain. That's the same effect size as propranolol or amitriptyline. When biofeedback is combined with propranolol, there is a 70% effect size, which is quite significant.
And this brings us to the conclusion of our 30-minute whirlwind tour of what would possibly be a longer didactic. I really thank you so much for inviting us to be part of your conference once again. I want to say that the plan is meant to be dynamic, it's meant to be fun, it's meant to allow 4 or 5 people to present during one 2-hour session, for an example, of didactics. And especially in this time of COVID, we absolutely understand the need to make our adaptations. The point of this activity is to contribute to physician wellness by encouraging development of more non-pharmacologic tools that include manual medicine skills, observation, breath awareness, and great variation. So thank you all. You'll find some email addresses at the bottom of our PowerPoint. Please feel free to reach out to us. Thank you.